Good afternoon, and welcome to Plenary 2. Please welcome Dr. Michael Boyle, President and CEO of the Cystic Fibrosis Foundation.
Well, welcome to the second plenary of the North American Cystic Fibrosis Conference. I hope that you've already been experiencing that mix of learning and connecting and being inspired that makes this event so amazing. Now, we're going to start into Plenary 2 shortly, but first let's take a moment for some special recognitions for some people who really deserve it. We're going to start by recognizing and thanking the two honorary chairpersons of this year's conference, both of whom have had remarkable impact over their careers on CF. Dr. Nicole Mayer-Hamblett is a professor in the Department of Pediatrics at the University of Washington, as well as an adjunct professor of biostatistics. Nicole has been an essential part of the Therapeutic Development Network, or TDN, for over 2 decades, and is currently the co-executive director of the TDN Coordinating Center, where she oversees the design, implementation, and analysis of just about every multi-center CF clinical trial that we conduct. I would say that any important multi-center clinical trial that's been sponsored by the CF Foundation over the last 20 years, whether it was Simplify or Optimize or the original azithromycin trial, was either designed by Nicole or she was involved in assessing the results. She's also been a thought leader for us in all of our interactions at the Foundation with the FDA to make sure that we advocate for the most efficient way to advance the therapies that we know are making such a big difference in the lives of people with cystic fibrosis. So Nicole, we thank you. We are so grateful to you for your wisdom and your leadership. Speaking of, she's gonna get her moment in a second. So speaking of wisdom and leadership, Hank Dorkin is a pediatric pulmonologist and a researcher with over 50 years of experience in CF. Much of that time, he's been the esteemed director of the Cystic Fibrosis Center and the CF Clinical Research Program at the Boston Children's Hospital, which is only about 3 miles away from where we're sitting. There you go. I hear you, Boston Children's. Along with his long impact on CF clinical care and research, Hank has been a dedicated mentor for many, many CF caregivers and served as the chair of the CF Foundation's Professional Education Committee for nearly 2 decades, where he's overseen the awarding of training grants to innumerable CF clinicians and researchers. Now, if you're in the audience and you've ever received a training grant from the CF Foundation, Hank was likely involved. So Nicole and Hank, on behalf of the entire CF community and individuals with CF everywhere, please stand so we can thank you. So grateful for you guys. All right, today it's also my honor and a great pleasure to recognize and thank an exceptional leader and someone who's been dedicated to people living with CF and the CF Foundation for many years. After more than 20 years as a guiding light at the CF Foundation, Dr. Bruce Marshall retired as our Chief Medical Officer in July. Bruce joined the Foundation back in 2002, coming to us from the University of Utah Medical School, where he served as an associate professor of medicine and director of the adult CF program there. Now, Bruce was initially hired to launch the Foundation's quality improvement efforts. Working with colleagues at the Dartmouth Medical School, he developed and implemented a strategic plan to accelerate improvement in CF care, leading CF center directors in an ambitious undertaking to establish high-quality, multidisciplinary care across the network. Bruce is a quiet but fierce innovator, and he led the charge in our commitment to quality improvement that still remains central in our strategic approach to care today. So many of the things that we take for granted today originated with Bruce, and a couple of those that came to mind included just the central importance of a partnership between the care team, people with CF, and their families to enable the best care, benchmarking to identify and disseminate best practices, creating collaboratives and mentorship opportunities to develop leadership in CF care, and developing evidence-based guidelines for CF care, and then transforming the CF patient registry, which is now poised to become an even more powerful tool for care teams and people with CF and their families. Now, throughout all of this work, Bruce has always led with a commitment to excellence, vision, and a heart for what is best for people with CF and their families. Now, let's hear from a few others who have worked closely with Bruce over the years.
Imagine a person with CF not needing airway clearance, not needing pancreatic enzymes or inhaled therapies, not needing hospitalizations. It's really exciting to imagine such a future.
Before modulators, people with CF like me relied primarily on high-quality care to extend our lives and enhance our quality of life. Under Bruce's dedicated leadership, the care landscape continued to evolve, bringing hope and better outcomes to countless individuals in the CF community. It's truly incredible to think about the many lives Bruce has improved during his time as a physician and leader at the CFF.
I think that Bruce has had an ability to see that care could be better for people. By listening, Bruce has been able to establish goals for quality improvement that have allowed us to do better jobs and for people to be healthier.
He's always been very calm, very approachable. He has a way of including everybody.
He's so thoughtful, and he has these brilliant ideas, and he doesn't shout them. He says them quietly, and people listen because he has the right idea.
The work I've done with Bruce, there was pressure to try to get it out, but he really made sure that people understood, don't rush it, you've got enough time. And so that focus has been really, really important.
Early on in the creation of the CF Foundation, it was realized that developing a registry is really going to be the key to understanding the natural history of cystic fibrosis. When Bruce came to the foundation, he saw the registry as a tool to be able to enhance care.
Bruce invested time and energy into making the registry the best it could possibly be, and that data really helped drive the quality improvement movement that Bruce led for many, many years. Bruce, I will be forever grateful for the ways that you improved so many lives of people with CF, including my own.
So Bruce, that video begins with you stating a vision of a better world for people with CF, right? And your career has been all about fulfilling that vision. So I love those words, caring, cool, calm, and classy through it all, the big 4 C's. That work you started 20 years ago has transformed CF clinical care. So thank you. Can you come on up to the stage so we can recognize you?
Thank you all. I want to follow up on Mike's word from the first plenary, gratitude. I'm so thankful to be a part of this community and reflected back on you. You all did the hard work. people with CF and their families, clinicians, care teams, researchers. You all did all the hard work, so the thanks comes back to you. Thank you so much.
All right, well, one other good piece of news. Thank you, Bruce. Again, amazing impact. We couldn't be more grateful. We know that CF clinical care is not going to miss a beat in the years ahead, and we couldn't be more delighted that Dr. Al Farrow, who has been a leader in CF care for decades, assumed the role of Chief Medical Officer at the CF Foundation in July, and is already leading next steps into a future of great CF care with the just published CF clinical care and care team guidance papers, as well as plans to launch the new CF patient registry in 2025. So we're looking forward to what's ahead, Al, and we're excited about your leadership. Thank you. All right, let's turn our attention to Plenary 2, and I'm delighted to invite two esteemed colleagues to introduce the session. So please welcome Dr. J.P. Clancy, our Senior Vice President of Clinical Research, and Dr. Katherine Tuggle, our Senior Director of Research, to introduce this plenary.
Bruce. Thank you. I did not want to be back there for that part. It was lovely to see. So thank you, everybody, and good afternoon. Mike, thanks for bringing us in. And my name is JP, if you don't know, and that over there is Katherine. And we are thrilled to introduce the plenary, and I'm going to turn the microphone to Katherine to begin this introduction. So please take it from there.
Perfect. Thanks, JP, and good afternoon, everyone. It is our great pleasure to introduce the topic and speakers of today's plenary about cystic fibrosis-related diabetes, or CFRD. This complication is becoming more and more common in our community, affecting up to a quarter of adolescents and nearly half of adults with CF. CFRD is associated with many complications that greatly impact the quality of life and survival. We often hear from our community that the diagnosis of CF-related diabetes adds a major treatment burden on top of an already complex care regimen. As the CF population continues to grow in age, understanding the impact of CFRD on CF infections, lung function, nutrition, and age-related problems like cardiovascular disease are going to become more and more important.
So back in the day when I was in medical school, yes, it was a few days ago, but back when I was in medical school, CF survival was really only into early adulthood, and to be honest with you, CFRD was kind of an afterthought. Our understanding of the disease was really limited. We knew that CFRD occurred through the loss of insulin production over time, and that was really about it. My, oh my, how our view of CFRD has changed. The primary defect in CFRD is low insulin production by the pancreas. But what you're going to hear about today is how much more CFRD is today from both a personal and molecular perspective. The importance of CFRD was recently highlighted in 2021 when we teamed up with the NIH and hosted a symposium and workshop on this topic. This event brought together CF and diabetes scientists, clinicians, and CF community, serving to catalyze a lot of the newest insights that you're going to be hearing about today.
I think it's safe to say that CFRD is having a moment. We have two extraordinary researchers who will discuss recent advances and exciting new directions in CFRD, including basic science and clinical research. To take us on this journey, I'm delighted to introduce our first speaker, Dr. Rebecca Hull-Meichle, who is the professor of cell biology at the University of Alberta in Edmonton, Canada. And she is the Canada Excellence Research Chair in the islet microenvironment. She received her PhD from the University of Nottingham in the UK, and then moved to the University of Washington, where she completed postdoctoral training and developed her independent research laboratory focused on the pancreas microenvironment and islet cell dysfunction and diabetes. During her time there, she was recruited by the CF Research Center to bring her type 1 and type 2 diabetes research expertise to CFRD. Today, her research program includes projects and collaborations around the globe with a major focus on understanding the pancreas pathology in CF and the underlying mechanisms that islet failure can lead to in CFRD. She will give us a view of the CF pancreas under a microscope, focused on new insights and cellular events that may underlie CFRD and how they may translate into new treatments.
You are going to love her presentation. It is so cool. And then you're going to have the opportunity to hear from Dr. Melissa Putman, an associate professor at the Harvard Medical School and director of the Massachusetts General Hospital Endocrine Research Center. Dr. Putman completed her medical school training at UNC Chapel Hill, residency at Mass General, and endocrinology fellowships at both Boston Children's and Mass General. She has spent the past decade caring for people with CF as a CF endocrinologist. She is a recognized leader in clinical research of endocrine complications in CF, including CFRD and new diabetes technologies. She is a mentor to many, and she collaborates extensively through the CF research community. Dr. Putman will take us through the changing landscape of CFRD in the post-modulator era, which includes new technologies, new treatments, and actually redefining what nutrition means for CF. I cannot think of two better qualified colleagues than Drs. Hull-Meichle and Putman to take us on this journey. So please join me in welcoming Dr. Hull-Meichle to the stage.
Good afternoon, everybody. I am so delighted and humbled to be here today. I want to thank JP and Katherine for such a wonderful introduction, and also, in turn, Melissa and I would like to thank them for the spotlight that they have shared on CFRD, for their support of research, and for our ability to share our insights and knowledge in this plenary session today. I don't have any disclosures to share with you, but I would like to say that my research is supported by CFF awards. Okay. So I want to start this afternoon by acknowledging and recognizing that now we understand that CF is a full body disease. Here are just some of the tissues that we appreciate are involved in CF, the airways, of course, but many, many others. The topic of today's plenary session is CF-related diabetes. And diabetes is defined as a disease of glucose or sugar metabolism. And when we think about glucose metabolism, that is also a full body process. And you might recognize as I've switched these slides that some of the organs that are on the previous slide associated with CF are also on this slide as well. So very briefly, the brain at the top of the picture is involved in coordinating and sending out cues when nutrient stores are low to drive food intake. The nutrients are absorbed through the intestines on the bottom left, and that nutrient absorption stimulates hormone production from the pancreas shown on the bottom right, and we are going to be talking a lot more about the pancreas this afternoon. The pancreatic hormones are then released into the bloodstream where they have actions in many tissues around the body, including the liver, adipose tissue, and skeletal muscle. And the kidneys are also important in filtering and reabsorbing glucose into the blood to maintain normal levels. So I mentioned we're really going to focus on the pancreas today. One of the reasons is that the pancreas is critically important for the regulation of glucose metabolism, but we have also appreciated for many, many years that CF is also very much affecting the pancreas. And so I wanted to use this data from Dorothy Anderson in this landmark study, which was actually the first study to describe cystic fibrosis. She was a pathologist and really an amazing human being. And she described cystic fibrosis first in the pancreas. So we have known about pancreatic involvement in CF for a very long time. I want to use this study to make two other points. First, as you can see, I'm not sure if you can see actually, but trust me when I say, in 1938, unfortunately, people living with CF didn't really survive out of infancy. And so the cases that Dr. Anderson looked at in this study were from very, very young children. So we know that pancreas disease is an early abnormality in CF. This is just a subset of the data from her study, and if you're sitting at the front, you'll be able to see every single case on this graph has cystic fibrosis pathology in the pancreas. So we also know it's very common. And I'm going to show you some up-to-date data about that as we go forward. So I appreciate that perhaps not everybody thinks about the pancreas as much as we do in my lab. So I'm going to give you a little bit of an overview. So the pancreas lives in the abdominal cavity very close to the intestine. And if we zoom in, we can start to see what kinds of cells make up the pancreas. So there are two main compartments. First, the exocrine pancreas, and you can see that this makes up the vast majority of pancreatic mass. The most common cell type within the exocrine pancreas are the acinar cells that produce and secrete digestive enzymes. Those enzymes travel through the pancreatic duct, shown in green on this scheme, and the duct is lined by epithelial cells, which we'll talk about on the next slide. The remaining part of the pancreas, the endocrine pancreas, comprises the islets, and they're only about 1 or 2% of the pancreatic mass. But these small, mighty little organs are what is important for the maintenance of glucose metabolism. So the islets are actually quite complicated little mini organs, but I'm going to talk about two main cell types today. They're both hormone-producing endocrine cells, the beta cells that make insulin, and the alpha cells that make glucagon, and we'll talk about what those hormones are and what they do in the body as we go forward. So then what happens to the pancreas in CF? So firstly, it's important for us to understand under normal conditions, with no CF, what is the impact and the role of CFTR in the pancreas? So we heard in yesterday's plenary session that with that really nice analogy of the car driving across Boston being the chloride ions, in the pancreas, actually, CFTR takes a different ion across the cell boundary. So you can see bicarbonate, or HCO3-. It's secreted out into the pancreatic duct. And it has a very important role to maintain pH in the pancreatic duct and to stop the environment from becoming too acidic. It's also important in water balance and maintains those digestive enzymes shown on the right in a dilute and inactive form. So consequently, when we lose CFTR expression or activity in the pancreas, as shown in by those red X's, we see a drop in pH, so acidification, and a drop in water concentration, leading to this concentrated acidic protein secretion. That's really bad news for the pancreatic duct. We get precipitation and obstruction, blockage of the ducts. This leads to inflammation and eventual destruction of the acinar cells. So as I mentioned, we spend a lot of time in my lab looking at the pancreas down the microscope, and so I'm going to share a little bit of the observations that we and others have made in this area. So we're very lucky in our lab to be able to access donor pancreas tissue from people with and without CF, so we can really look at what is happening in this disease. So first, on the left, we have an example of a pancreas from somebody with no CF. And first, in blue, you can see these acinar cells that, again, are all over the pancreas. They're the most abundant cell type. Here are the ducts. I've colored the large ones in pink so that you can see them, but the small ducts actually percolate all through the pancreas. And then the islets are shown here. In this case, the dark brown staining is insulin, marking the beta cells, but the alpha cells are there as well. Now, if we compare that to what we see in CF, I would say that you probably don't need to be a pathologist to recognize the differences between these two pictures. I'm going to lay out the big changes that we see. Firstly, interestingly, we can see ducts in some cases, but as I mentioned on the previous slide, the ducts are plugged. We see almost no evidence of acinar cells anymore, and instead, fat infiltration, which we think comes in to fill the space left behind by the acinar cells. We see accumulation of fibrosis or scar tissue through the pancreas, all the way through the pancreas actually, but particularly around the islets. And I think you can appreciate that the islets are still clearly visible, which is kind of a surprise given the remodeling and destruction that is happening around them. Now, if we compare what I've shown you in this picture to what we typically see in pancreas in somebody with CF-related diabetes, I think you can appreciate that in general, these look very similar to each other. And in fact, if we look at several measurements, which I don't have time to share with you today, we find that there's actually very little difference in the pathology in people with CF with and without diabetes. And so we believe that actually it is early changes to the CF pancreas pathology that predispose people to diabetes. And so that's what we've really focused on in my lab. Okay, so I've shown you some pictures, but when we look at data from the CF Foundation registry now, how common is the exocrine and endocrine pancreas disease in CF? So first on the left, these are data from the 2023 data set from the CF registry, and we're looking at pancreatic enzyme replacement therapy or a measurement of exocrine pancreas insufficiency. And so you can see even from the very youngest cases on the left of this line that is very common. About 80% of people living with CF have pancreatic exocrine dysfunction. This seems to decline with advanced age, but I'm going to talk about why we think that is in a minute. On the right, we have data from the same registry data collection, And now we're looking at the relationship between CF-related diabetes and age in blue, or impaired glucose tolerance or pre-diabetes in red. And here we're seeing a different pattern. So to begin with, in the very youngest subjects, we see that the rates of both pre-diabetes and diabetes are low. This jumps up sharply at age 10, and that's because that's when screening begins. And Melissa will talk a lot more in her presentation later on today about screening for CF-related diabetes. So then pre-diabetes rises up and plateaus around 20 years of age, and that's what we would expect because pre-diabetes is a very high-risk condition for developing diabetes, so people will often transition from impaired glucose tolerance to diabetes. So diabetes continues to go up and then plateaus probably around 40 years of age, and then also seems to decline. But actually, unfortunately, this doesn't mean that people's pancreatic, exocrine, and endocrine disease is going away. What this means is that there's what's called a survivor bias with these data, such that the people who survived out to the right-hand side of this graph are actually free of pancreas disease. So I'm going to show you this in another way, at least with respect to cystic fibrosis-related diabetes. And for this, I really want to thank Scott Blackman for making me think about diabetes in this way in the CF population, for sharing his data, and also acknowledging the rest of the CFTR2 consortium who have been looking at this very important question. So on the y-axis, up and down, we're looking at CFRD prevalence. And on the x-axis, left to right, we're looking at age. And so you can see that this data comes from a very large cohort of people. In dark red, we have a group of people that have no CFTR function. And I think you can appreciate there's a very, very strong relationship between diabetes and age. And it doesn't plateau around 48 years of age. In fact, it continues to increase until it reaches about 100% around age 65. In the blue line, we can see a group of people that still have partial CFTR function, and you can see that they are somewhat protected against diabetes, at least in the earlier ages. But once they hit 40, their diabetes rates also increase and continue to increase over the lifespan. So I've just used this dotted line here to designate what is currently considered the mean survival of people living with CF in the US. And you can appreciate at this age, 61 years, that the rates of diabetes in both of these groups are very high, much higher than the general population. And Melissa will talk more about the impact of that. Also, I want to make the point that these data are pre-modulators, and Melissa will also talk about the impact of modulators on diabetes later on. So this is a very serious and common problem in diabetes. And as JP mentioned, we know generally from a clinical standpoint what is causing people to develop diabetes. So this gives me a chance to share this fantastic data from Andy Kelly and really to acknowledge her major contributions to this field. So what Andy's group did was to measure plasma glucose or sugar levels in people. And then on the right, we're going to look at a measurement of how well the insulin-producing beta cell actually secretes insulin into the peripheral circulation. So first, we're going to orient you by explaining what we would expect to see in the normal range. So to start off with, blood glucose levels are low. The people in this study were given a standardized meal, which causes glucoses to spike, and then they return back to normal by about 2 hours. And the reason for that is that insulin is secreted very efficiently in this early insulin response, which is this peak that you can see around 30 minutes. There's also a second phase response, and again, the insulins also go back to normal by about 120 minutes. Now, if we compare this to somebody or a group of people living with CF that don't meet any diagnostic criteria for diabetes, you can see that their glucose profile looks different. It's not higher, but it's certainly delayed, and it takes quite a lot longer to get back to normal. And the reason for that is because we're losing the first phase insulin. That early phase insulin peak is very much reduced, and now we're seeing a blunted and delayed insulin response. As people progress in their loss of insulin release, we see worsened glucose tolerance. So this is a group of prediabetes. I showed you the incidence of that on one of the previous slides. Here now you do see an increase in glucose levels about 60 or so minutes after the meal, and that take way longer to get back to normal. And I think you'll appreciate that once they reach normal, they actually overshoot, going into the hypoglycemic or low range. And this is very common in people living with CF, and Melissa, again, will talk about that as we think about how to manage and treat this disease. So the reason for this increase in glucose tolerance is that we're losing this early insulin release altogether, and again, we're seeing this blunted and delayed insulin response. So that by the time people actually meet diagnostic criteria for CFRD, their glucose excursions are very much significantly increased, and their insulin release is very blunted. So what I'm going to try and tell you for the rest of the afternoon is what we understand about why this might happen, with the goal of trying to understand what we might be able to do about it. So the most simple explanation would be that CFTR is expressed within the insulin-producing beta cell itself, and that mutations in CFTR could have a direct effect to impair insulin release. And there is certainly some data to support the fact that that might happen under certain conditions. But I would say that by and large, the field agree that the beta cell doesn't make very much CFTR at all. And so the way that we show this is data from Michael White and Jim Shaw in the UK, kindly shared it with me for this talk. And you can see on the left, we're looking for messenger RNA. We heard a lot about messenger RNA yesterday. We're looking for brown staining, and I've highlighted the islet for you in the dotted red line, and I think you can appreciate that there really is not very much of any CFTR mRNA within the islet. And that's confirmed at the protein level. The upper panel shows insulin staining in red. Again, we're getting good at seeing where the islets are now. And the CFTR is really not in the same place as the islets. The bottom panel is a control to show that the CFTR is in fact co-localized with the ductal marker keratin 7 as we expect. So it seems that there's unlikely to be a major effect of CFTR within the beta cell itself, but perhaps there's an indirect effect by which CFTR mutation causes destruction of beta cells, like we see in type 1 diabetes. So as I mentioned, we're very lucky to be able to get access to human tissue in my lab. And here is a cohort. I'm going to show you several pieces of data from this study, so I'm just going to orient you for a minute so that you can follow along more easily. So each individual point, either a circle or a triangle, is a piece of pancreas from an individual donor. Those donors either are classified as not having CF in gray or CF in orange. And both of these groups were age and sex matched. What I think you'll appreciate in the gray symbols is there's this huge variability in insulin area per tissue area, and that's what we would expect. It's a very heterogeneous measure. But in our cohort, we see the complete same range of insulin area in our CF, so that there's absolutely no difference. So we think there's some studies that suggest that there might be a small difference in beta cell area, but we think that beta cell destruction is not why people are getting CF-related diabetes. So the last thing I want to talk about with respect to the beta cell itself is gene expression. So as an islet biologist, there is a family of genes that we consider to be critically important for the maintenance and health and function of the beta cell. So these are data from the Vanderbilt group, where they had actually been able to isolate islets from donors with and without CF and look at the expression of these genes. Again, the individual circles denote an individual case. And then we're looking for coordinated changes, either increases in the red bars or decreases in the green bars. Now, to be considered statistically significant, these bars have to come outside that gray bar that you can see in the middle. And surprisingly, we really don't see any difference in these genes. That's not what we would expect to see. When we look at other more common forms of diabetes or animal models, at least some of these genes would be expected to be changed. I'm going to come back to the very last one on the graph in the next slide. So together, we consider that the islet beta cell is relatively and surprisingly spared in CF. Okay, so we need to look outside the beta cell for clues as to why people are developing CF-related diabetes. So when I introduced the islet at the beginning of the talk, I mentioned two different kinds of hormone-producing cells. This is the other one, the glucagon-producing alpha cell. And this study, if you can see the bottom, this is from 1991, and I think still remains one of the best studies in the literature, looking at the impact of CF on glucagon release. And this gives me the opportunity to really acknowledge the massive contributions that Tony Moran has made to this field. So in this study, Tony took a group of individuals and gave them arginine. You can see where the black arrow is. Arginine is an amino acid or a component of protein, and it is really good at stimulating glucagon release, as you can see by the gray peak. Now, if we look at this same test in people living with pancreatic sufficient CF, you can see that the glucagon levels are decreased at every time point, especially after arginine stimulation. And then if we look at people with pancreatic insufficient CF or CF-related diabetes, you see a progressive loss in glucagon release, really very much like that progressive loss in insulin secretion that we saw earlier. So why would we care about a decrease in glucagon release? What does that have to do with diabetes? So I would say that there are two reasons why this is important. Firstly, glucagon and other products that are secreted by the alpha cell actually stimulate insulin secretion. And so perhaps this loss of alpha cell function is one of the reasons why we're losing insulin secretion in CF. Separately, glucagon is one of what is known as a counter-regulatory hormone, so that when glucose levels fall below the normal range, glucagon secretion is important for restoring them back up into the normal, safe range. And if you remember earlier, I mentioned that hypoglycemia is very common in people with CF. This loss of glucagon release is one of the reasons why. Okay, so this is what alpha cell function looks like. What about alpha cell abundance? So these are data from exactly the same set of samples that I showed you for the beta cell, but here we see a very different pattern. Again, we see some variability among the groups, but here we see a consistent increase in the number of alpha cells in CF, and this is very consistent across the literature. So we don't really know why this is happening. This is quite surprising, right? So we're seeing a decrease in alpha cell function, but an increase in alpha cell abundance, suggesting perhaps that the alpha cell is trying to compensate for this lack of glucagon release. We also get a clue to what might be going on with the alpha cell when we look at this same data set that I showed you in the previous slide. And I mentioned I was going to come back to this gene at the bottom, ARX. So out of all of this family of genes, the only one that is statistically significantly decreased is ARX. And it turns out that ARX is a master regulator of glucagon secretion and of alpha cell identity. So taken together, we think that the islet alpha cell actually exhibits more abnormalities than the beta cell. That's kind of surprising. And this is an active area of research. We still have a lot to learn in this area. Okay, so aside from the islet endocrine cells, there are other support cells within the islet that are very important for its function. And in my lab, we've studied the islet microvasculature, or the blood supply to the islet, for many years. This beautiful image from my lab is actually from a mouse islet, but it really beautifully illustrates the, a couple of things. Firstly, the green staining shows how many blood vessels there are in the islet, and also how closely associated they are both with the insulin-producing beta cells and the glucagon-producing alpha cells. So it turns out that the blood vessels are very important for the islet. So blood vessels bring oxygen and nutrients like they do to all tissues, but in this particular case, the glucose and amino acids that are necessary to stimulate insulin and glucagon release in response to a meal come through this capillary network. And then conversely, the hormones, when they're released, need to get through that capillary network out into the body to have their biological effects. So you can imagine that if something happened to this blood supply, it would be really quite bad for islet function. And so using this same collection of human pancreas, Josh Castillo, when he was a fellow in the lab, started an analysis looking for the presence of blood vessels within the pancreas. So he uses a stain called CD31, which is a classical vascular endothelial marker. And I hope you can see, I've shown the arrows because it's a little bit harder to see than the insulin and glucagon. The brown staining within the islet on the top in the non-CF pancreas. The islet is denoted by the black dotted line. And I think you can see that there's abundant CD31 staining both within the islet and also out in the exocrine pancreas. On the bottom panel, we're looking for evidence of CD31 staining in the CF pancreas. And if you're struggling to find any in that picture, then you're certainly not alone. Because when Josh quantified this data, he found that there was a substantial decrease in islet vascular area as well as exocrine pancreas vascular area. So we conclude from these data, and we're still working on this study actually, that density of blood vessels is decreased both in the islets and in the exocrine pancreas in CF. And I should say, just as a side note, this is very, very different from what we see in other forms of diabetes. And so we think that this is something that's unique about the pathology of CF, and is something that we're following up on. Now, if you're paying attention, and I'm sure that you are, you may notice that there is a pesky little point on this graph that doesn't completely follow this beautiful pattern that I've just described to you, and that's just science in a nutshell. And so there's this point up at the top, and we're thinking, what on earth is going on with this? So it turns out that this point is the same individual in both cases. And actually, unfortunately, this is the very youngest of our cases within our cohort. It is an infant. And it's the only one of the CF cases that we have that still has intact exocrine pancreas. And so while it's preliminary data, we think that it is suggestive of the fact that the loss of blood vessels is something that occurs in secondary to the loss of exocrine pancreas, and we're going to be looking at that a lot more in the future. So the last piece of primary data I want to show you is actually the first thing that I did in this field. And this gives me the opportunity to thank and acknowledge Bonnie Ramsey for getting me started in this area and for her support throughout my career in this field. I also want to thank Ron Gibson, who I'm pretty sure is in the audience, and Sharon McNamara, who I hope is also in the audience, as well as Gail Deutsch, who's a pediatric pathologist. All of these guys are at Seattle Children's, and without Ron, Sharon, and Gail, I would not have access to this tissue that I've shown you the data from today. And so Ron was working on a clinical study and was interested in getting us to look at interleukin-1 beta, which is a pro-inflammatory cytokine. And this is not something that is typically considered to be highly expressed in the islet, and so I must say I was a little skeptical that we would see anything. But again, CF is very different from some of these other forms of diabetes that we're used to looking at. And as you can see from the bottom right panel here, there's lots of IL-1 beta in the CF islet, suggesting that it is a highly inflamed environment. When we quantify this across our cohort, you can see that most of the CF cases have some IL-1 positive islets. Again, we have these interesting cases in our no-CF group that have high levels of IL-1 beta, and we still actually don't know why that is. So independent confirmation of the fact that there's inflammation within the islet comes from that same paper I showed you before. Again, this is gene expression data, but in this particular graph, they're looking at inflammatory markers. So these might come from many places within the islet. There's evidence that autoimmune T cells, or not autoimmune, adaptive immune cell T cells might be present in the pancreas. But we also think that some of these inflammatory markers might be coming from the vasculature, the residual vasculature that is present in the islet in CF. And so together, this high level of inflammation is likely to be very detrimental to hormone production and secretion. So I've taken you on a tour of a little bit of what we know already, but we're still really scratching the surface of what is happening in the CF pancreas. And so what's next? So in our group, we are really delighted to collaborate with Kyle Galton, who's an expert in next generation sequencing technologies. And we're looking at donor pancreas from people with and without CF, and are doing sophisticated studies looking at gene expression, single nuclear RNA-seq, and also gene regulatory patterns, as well as this really powerful technique, spatial molecular profiling, that will allow us to look at gene expression within the two-dimensional space in the CF pancreas, looking at how cells communicate with one another. We're really excited to hopefully show that data at next year's NACFC. And lastly, I want to just call out some really amazing work that's being done in using live human donor samples to look at the interaction between the exocrine and endocrine pancreas. We're doing some of this work in our lab, but I wanted to call out the really innovative work that Kishik Mon is doing at Cedars-Sinai, where he takes donor pancreas material and isolates the ducts along the top or islets along the bottom, and then puts them together in his pancreas on a chip model that he made. So he can really look at the interactions and do mechanistic work to try and understand why people are getting CF-related diabetes. Okay, so to summarize, I've told you that diabetes is a common complication of CF and is likely to increase in prevalence as the CF population ages. That we know insulin deficiency is very common in CF, but the beta cell itself seems relatively unaffected. However, there are multiple cell types within the islet and pancreas that exhibit severe abnormalities in function and phenotype in CF, and ongoing work to better understand these abnormalities will help develop improved treatment options for people living with CF-related diabetes. So I'd like to thank you for your attention. This is my acknowledgement slide, and now it's my pleasure to turn over the stage to my colleague, Melissa Putman, who's going to talk to you about the clinical aspects and the changing face of CF-related diabetes. Thank you very much.
Thank you so much. It is such an incredible honor to be here today, and I am so excited for this opportunity to share with you all the clinical side of CFRD research. Here are my disclosures. So the goal for this talk is to answer some of the important questions that are facing the field of clinical research in CFRD. To start, I'd like to give you some background on the clinical characteristics of CFRD, why it is so important for people, and why it can be such a problem in patients with CF. As you may know, type 1 diabetes is characterized by the autoimmune destruction of beta cells, leading to an absolute insulin deficiency that requires lifelong treatment with insulin. Now, type 2 diabetes, on the other hand, is characterized by a rising insulin resistance that leads to the gradual onset of high blood sugars. It is often, but not always, in the setting of obesity, and there are multiple non-insulin therapies available to treat type 2 diabetes. Now, CFRD shares some of these characteristics, including insulin deficiency, insulin resistance, a gradual onset, and the need for insulin treatment. But CFRD really is its own unique form of diabetes with distinct characteristics that make it very different from type 1 and type 2 diabetes. So we heard from Rebecca that CFRD is characterized by a progressive beta cell dysfunction that has a delay in first phase insulin secretion that can predispose to low blood sugars. There's also a highly variable clinical course that can be complicated by infections and steroid treatments that can increase insulin resistance even more. And CFRD is often associated with undernutrition rather than overnutrition. These differences can lead to unique challenges that people with CF face in managing their diabetes. First, there are limited screening tools available for the diagnosis and screening of CFRD, and we'll talk more about this in a minute. Also, there's the burden of an entirely new disease. People with CF spend so much time and effort taking care of their lungs and other aspects of CF, and then we add an entirely new medical problem with new tasks like insulin injections and carbohydrate counting and glucose monitoring, and this can be overwhelming. There is also variability in insulin production between different people with CFRD. So whereas some people may need just a few units of insulin with meals here or there, others may need large doses of insulin multiple times per day. And so it's important that interventions be tailored to each specific individual. But even within the individual, insulin needs can often change. Where someone is healthy, they may need much less insulin, and when they're sick, they need much more. There's also the risk of spontaneous low blood sugars, and insulin can also cause low blood sugars. So it can be challenging to start insulin in someone who's already having hypoglycemia. And then finally, people with CF often have high-calorie nutritional needs to maintain a healthy BMI, and this can mean high carbohydrate, high sugar foods that can be challenging to control with insulin. And these challenges can really tip the scale for people with CFRD. And there are also unique complications that diabetes can cause in people with CF. So we know that insulin deficiency and high blood sugars can cause glucose on airway surfaces, and this can lead to an increased risk of infection and inflammation, which can then make insulin resistance worse and make blood sugars go even higher in a vicious cycle. And so it's not surprising that studies have shown that the diagnosis of CFRD has been associated with a compromise in nutritional status, with reductions in pulmonary function and an increased risk of CF exacerbations and earlier mortality. And this is in addition to diabetes complications that we see in all patient populations, including eye, nerve, and kidney disease, and not to mention the effects that diabetes can have on mental health. And so for this reason, diabetes can have a substantial effect on the health and longevity of people with CF. And as we heard earlier from Rebecca's talk, there will be an increasing number of people with our aging CF population that will likely have to face these challenges in balancing this burden that diabetes can cause. So this leads to our next question. How do we diagnose and treat CFRD, including areas where we have room for improvement? The oral glucose tolerance test, or OGTT, is the screening test of choice for CFRD, and this test is recommended every year in all people with CF over the age of 10. And the reason that this test was chosen in particular is that the diagnosis of CFRD by this test has been correlated with important CF outcomes like pulmonary function and nutritional status. But as I'm sure everybody in this room is aware, this is not an easy test. People have to come into clinic after fasting for 10 hours overnight, and then they have to drink 75 grams of straight sugar within 5 minutes and have their blood drawn 3 times over the next 2 hours. This test is time-consuming, this test is burdensome, and this is likely why, over the past 20 years, our screening rates for the OGTT have been suboptimal in children here in the dotted line, and particularly in adults here in the solid line. And you can see in 2023, just over 30% of adults with CFRD underwent their recommended OGTT screening test. A screening test is only useful if it is actually being performed, and we are missing the opportunity to diagnose and intervene early for so many people. The problem, though, is that other tests that we use for diabetes in other populations aren't as sensitive in people with CF. And I want to tell you exactly why this is. So this graph right here is showing you blood sugar levels on the y-axis and time from midnight to midnight on the x-axis. And that shaded blue area is the normal range for blood sugars. Now, checking a fasting blood sugar level is a very useful way to screen for type 1 or type 2 diabetes, but this is often normal in early CFRD, and it doesn't usually become elevated until very late in the course of diabetes. Another way that we routinely monitor blood sugars in other diabetes populations is to check levels by fingerstick glucose before each meal. But again, this is often normal in people with CF, in early CFRD. And so more recently, we have a new tool available called continuous glucose monitoring, or CGM. And this is a sensor that goes on top of the skin, and then there's a tiny filament the size of 2 cat hairs that goes just underneath the skin, and it measures blood sugar levels continuously over the course of the day and the night. And what we have learned from using CGM in people with early CFRD is that they have a very unique glycemic pattern with large glucose excursions to the 200 to 300s occurring after meals. But these are typically very short-lived, and sometimes they're followed by low blood sugars, as you can see here. And so this is showing how these typical routine ways that we monitor blood sugars in other populations, these will miss the glycemic variability that can happen in early CFRD. Now, if we look at multiple days at a time, with each day represented by a different color, you can see just how variable glucose levels can be, with peaks and crashes occurring all over the course of the day, but with relatively normal levels while fasting overnight. Now, if we look at the average blood sugar over the course of this period, well, you can see on average, that's actually normal, and that's this dark line right here. Now, hemoglobin A1C is the most commonly used screening test for all diabetes populations, but hemoglobin A1C is a measure of average blood sugar over the past 3 months. And so sure, it's helpful if it's elevated, but a normal level may miss this glycemic variability and clinically significant high blood sugars that could be happening. And this is exactly why we have work to do to find better screening tests for people with CF. Moving on to treatment. At present, insulin is the only recommended treatment for CFRD. And this is because insulin therapy has been associated with improvement in all the bad things that diabetes can cause. Improvement in nutritional status, in lung function, and indirect data even suggest a survival benefit. And at present, no other medications have been shown to have these same improvements in these clinical outcomes yet. And we'll talk more about this in a minute. I'd also like to point out that our recommended blood sugar targets that we use for people with CFRD are the same as what we recommend for those with type 1 and type 2 diabetes. But these targets were established based on the development of microvascular complications like eye and kidney disease. But with CFRD, we're most interested in nutritional status and pulmonary function. And at present, there are no data to tell us if we should be using CF-specific glucose targets to optimize these CF-specific outcomes. So again, highlighting room for improvement in the treatment of CFRD. All right, and this leads us to our next question, and I'm sure this is a question that is on everyone's minds. What is the impact of highly effective modulator therapy, elexacaftor, tezacaftor, ivacaftor, or ETI, on CFRD? We have seen such improvements in lung function and nutritional status. Are we seeing the same for CFRD? I am excited to share with you some recent results from the PROMISE study, which is a longitudinal observational study investigating health outcomes in children and adults with CF as they started ETI. Now, the endocrine sub-study of PROMISE, led by Drs. Andy Kelly, Christine Chan, and others, collected data on glycemic outcomes, including the oral glucose tolerance test and hemoglobin A1C at baseline before people started ETI, and then again at 12 to 18 months, and finally at 24 to 30 months. And what they found was a small but statistically significant improvement in hemoglobin A1C from 5.8% to 5.5%, comparing baseline to the end of the study. But when we look at glucose categories, including normal glucose tolerance in the orange, early glucose intolerance in the yellow, impaired glucose tolerance or prediabetes in the green, and CFRD in the blue, you can see that a couple of participants went up or down on this scale, but overall there was no change in glucose categories over the course of the study. And so what these results are telling us is that ETI may cause a small decrease in blood sugars, but it's unlikely that it's going to make prediabetes or diabetes go away. Now, this is a very active area of research right now in the CFRD world, and so I would like to direct you to these abstracts being presented at this conference to find out more about ETI and CFRD. Also, we heard from Rebecca earlier today that the damage that happens to the CF pancreas happens very early in life. And so the next question is, well, what happens when we start ETI in younger children and even infants? And the BEGIN study, with the help of Dr. Katie Larson-Odie, is collecting CGM data on children under the age of 6 who are taking ETI. And so hopefully this study will give us additional insight to help us answer this important question. All right, I have just talked a lot about CFRD, but now I would like for you to hear about it from someone who is actually living with it. So I would like to introduce to you two very special patients of mine here in the Boston area, Alex and Emma, who have agreed to share their experiences on life with CFRD.
My name is Alex. I love to play music. I play guitar, bass, piano, and drums, and I like to record. I'm not eligible for one of the modulator drugs because I have a rare mutation. I was diagnosed with cystic fibrosis-related diabetes. I believe I was 12 years old. It was kind of a shock. At that time, I didn't even know that diabetes was a possible side effect of cystic fibrosis. It just felt so overwhelming. It was hard. It was very hard to process and to come to terms with.
My name is Emma. I just graduated from college with a chemistry degree. As of right now, I just got a job as a lab technician, so new things coming. My mom has always been my biggest supporter. Ever since I was born, she has always been the one to make sure I'm the #1 priority and that my health is the #1 priority. I've never felt any of that support waver.
Emma was pre-diabetic starting when she was 13. That was really, really difficult for me first because I knew what the future was going to be. And it was just crazy to me that this was going to be more for her than the CF. Like, we had CF under control.
To be honest, it didn't really affect my day-to-day life yet. It wasn't until I was officially diagnosed when I was a senior in high school that I had CFRD and I started treating it. It was definitely scary. To put another diagnosis on myself was kind of a lot to come to terms with. I even remember counting up the pieces of lettuce I would add to a salad just so I didn't miss any grams of carbs, and that definitely caused a lot of extra anxiety that I put on myself.
The process of accepting the fact that I was living with this and the fact that ignoring it would just make things worse for me was a pretty long one. I think I definitely went through the classic 5 stages of grief. You know, the technological advances that have come out, it completely changed my life. First, it was the Dexcom continuous glucose monitor that lets you see your blood glucose whenever you want without having to prick your finger, and then getting an insulin pump. When I used to think of my blood sugar, it gave me a lot of anxiety. And when I would check it, if it was high, it would make me feel bad about myself. It would make me think that I had made some sort of mistake, I'd done something wrong. But since I've had the continuous glucose monitor that lets me just see whenever I want, it just lets me think about it in a much more healthy way.
Emma took on her own care and was proactive from the start. It just was a natural progression. I was always in the background if she needed me. She just knew what she had to do and she did it. I've never thought of her as Emma with CF. She's just Emma. And Emma takes care of everything she needs to do with such grace. I only wish that I could be as strong as she is.
I would say that I feel empowered managing my CFRD because of my mom and also my care team. I've always felt like they believe in me. And when it came to me actually not being home and going to college and living on campus, I had to figure that out for myself. And it was more of a guessing game than being sure, like when I was home. But luckily, after my first semester living on campus, I was able to get a glucose monitor, a Dexcom, and I also got an insulin pump, which made things 10 times easier. I didn't have to do injections in the bathroom, at the dining hall, or in a dorm bathroom, anything like that. I could just do it right on my hip, basically. Every single advancement that comes out for CFRD and diabetes in general it makes such a difference in the daily lives.
It's amazing how far things have come, how far things are continuing to go. Thank you, because the advancements that they've already made have completely changed my life. I am really looking forward to whatever you have in store for the future.
And now we look to the future to explore how the landscape is changing for CF and CFRD, focusing on exciting new technologies and potential treatment options for CFRD, innovative observational multi-center studies to help us teach us about our changing CF population, and training CF endocrinologists now and for the next generation of CF. So as we heard from Alex and Emma, continuous glucose monitors, or CGM, can be a very helpful tool for managing CFRD. These devices provide real-time blood sugar data, including alarms if blood sugars are going too high or too low, They are small, easy to place, and have accuracy that are approaching, and in some cases even exceeding, traditional fingerstick glucometers. And these devices are making it possible for us to ask questions that we've never been able to ask before and to explore new areas of CFRD research. For example, can CGM potentially be used as a screening tool, something that's more convenient, more accessible, potentially in place of the OGTT? And this is a very hot topic of research right now, and so I encourage you to stop by these abstracts listed here to find out more about this. In addition, we know CGM can be helpful, but does it actually improve blood sugar levels in people with CFRD? And then also, can we use CGM to better understand how high blood sugars impact lung function and nutrition so that we can one day learn if we should be using CF-specific glucose targets to optimize these outcomes? And one of the most exciting and impactful developments in type 1 diabetes has been the integration of CGM with insulin pumps to develop devices called automated insulin delivery, or AID devices. And these devices will adjust insulin delivery automatically based on input from the CGM. And currently available AID systems have been shown in people with type 1 diabetes to improve blood sugar levels, to lower A1C, to increase the time spent in our target blood sugar range, all the while with stable and sometimes even decreased rates of low blood sugars. Now, to find out more about the specific AID system that Alex and Emma were using, you can read about this in a study led by Dr. Bryn Marks that's being presented at this conference. But it's important to point out that these devices still require a fair amount of work for both the patient and the provider. So from the provider side, I need to enter accurate insulin settings, and then these settings need to be changed anytime that someone's insulin needs change. From the user side, patients need to keep constant track of all their nutritional intake, to count up the grams of carbohydrates they're eating and drinking, and enter this information into the pump multiple times per day. And if blood sugars are elevated, then they need to tell the device to give more insulin to bring blood sugars down, called correction bolusing. Now, I'd like to tell you about a device, a specific AID device that we are studying in CFRD. And this device is a little different. So in this case, initialization requires only the user's weight, and then the device will learn what each individual's insulin needs are, and then continuously adapt to whenever these needs may change, which can be particularly helpful for people with CFRD whose needs can often change. In addition, there's no carbohydrate counting involved. Instead, users can enter qualitative meal announcements. This is a typical meal, more or less than typical. And finally, all correction dosing is automated. So if blood sugars are high, the device will automatically bring them down. We studied this device in a random order crossover trial over 4 weeks in 20 adults with CFRD, comparing usual diabetes care with the Bionic Pancreas. Now, this red line, the solid line, is showing you the average blood sugar over time from midnight to midnight, and that dotted red line is the variability, the interquartile range. And this was when people were using their usual diabetes care. Now, this blue line is showing what happens after they started using the Bionic Pancreas. There was a significant lowering of their blood sugar levels over the course of the day and the night with a much tighter range. And on survey responses, a majority of participants who were in this trial reported that they felt less burdened in managing their diabetes using the device. They had greater peace of mind, and they spent less time thinking about their diabetes. And in fact, one participant told us that when she was using the Bionic Pancreas, it felt like she was taking a vacation from her diabetes, where she didn't have to think about it all the time. And I am so excited to share with you our next step for bringing this device to the CF community, and that is Bionic CF. This is a multi-center, randomized clinical trial that will be starting at 15 CF centers across the country. We will be enrolling 150 adolescents and adults with CFRD who will be randomized to usual diabetes care plus CGM or the Bionic Pancreas over 13 weeks, followed by a 13-week extension period where all participants get to use the device. And our goal for this trial is to get FDA approval for this device for the indication of CFRD, which we hope will improve access and remove barriers for insurance coverage. And hot off the press, you're hearing it for the first time here, but we just enrolled our first participant in this trial this week here in Boston. So keep your eyes open for this trial coming to a CF center near you. All right, so in addition to this exciting advances in diabetes technology, another aspect of the changing landscape of CF and CFRD is the rising rate of overweight and obesity since the introduction of ETI in 2019. And this you can see here in the light blue and green bars. And this is getting closer and closer to the rates of obesity in the general US population, which is close to 40%. And with these rising obesity rates, we're finding new health problems emerging in people with CF that we really haven't seen that often before. And this includes metabolic syndrome, which is characterized by increased insulin resistance, which can make diabetes management more challenging for those with CFRD. Fatty liver, fibrosis, and cirrhosis, and people with CF are already at risk for CF liver disease. And also high blood pressure, high cholesterol, and an increased risk of heart disease. But this is also opening the possibility for the use of medications traditionally used for the treatment of type 2 diabetes or metabolic syndrome for use in CFRD. And I'm sure everyone here has heard about the rise of GLP-1 receptor agonists, which are very effective medications to treat obesity and type 2 diabetes in the general population. And one of the most common questions I get in my clinical practice these days is, what is the role of these medications for people with CFRD? And we have limited studies available, including 2 that are being presented at this conference, that suggest that GLP-1 receptor agonist will improve blood sugars and help with weight loss in people with CF. But we have to consider important side effects that these medications can cause specific to CF. Side effects like delayed gastric emptying, severe constipation, or excessive weight loss that may not be healthy. And so fortunately, there are ongoing clinical trials that are investigating the safety and efficacy of non-insulin therapies in people with CFRD. And this includes 2 studies looking at semaglutide, which is a GLP-1 receptor agonist, including one being presented as an abstract at this conference, and another led by Dr. Amir Mohit. And Dr. Mohit is also leading another trial with a different medication for type 2 diabetes called empagliflozin, which is a SGLT2 inhibitor. In addition, other studies are investigating dietary interventions for the management of CFRD, including one led by Dr. Kevin Scully, looking at a low glycemic index diet. And studies like these will open doors for one day the possibility that we will have more options available to treat CFRD. And speaking of nutrition, it is becoming increasingly clear that how we look at nutrition is changing in the post-modulator era, and we need new and better tools to understand and optimize nutritional status in the CF population. The Strong CF study is a multi-center, longitudinal observational study that seeks to redefine nutrition in CF, to find a better BMI, to shift focus away from fat mass and instead focusing on lean mass, muscle, function, looking for measures that we can use easily in clinic, measures that are reproducible, responsive to intervention, and are associated with important CF clinical outcomes that we care about, like lung function. And this study is collecting an enormous amount of information about body composition, muscle strength, physical activity and functioning, CGM blood sugar levels, of course, and many other measures that have a direct effect on nutrition. And you can read more about this study in abstract 635 being presented at this conference. And also, in more exciting news for you today, I would like to announce that we recently enrolled our 150th of 300 participants in this trial, meaning our halfway mark. And so I want to give a huge shout out to all the CF centers and all the study teams who are working so hard on this study. You can expect to hear more about the results from this trial at next year's NACFC. Another exciting multi-center study that promises to teach us about our changing CFRD population is the SPECTRUM study, studying the presence of CFRD complications with thoughtful recruitment of multi-ethnic minoritized groups. And this study is led by Drs. Andy Kelly, Suki Reyes, and Tanisha Daly. Now, these investigators recently published data showing that individuals who are Black and Hispanic have a higher risk of developing CFRD at earlier ages. And we know from other diabetes populations that these groups have a higher risk of developing diabetes complications. Now, in the past, we've always seemed like diabetes complications like eye and kidney disease were relatively uncommon in people with CF. But this is changing in this post-modulator era with our aging population. And this study is on the forefront to help us better understand and characterize diabetes complications in a diverse cohort with CF so that we can provide evidence-based guidance on the prevention and treatment and screening for these diabetes complications specific to CFRD. Another amazing development in the post-modulator era that we'll hear more about tomorrow is the rapidly increasing rates of pregnancy. And this is so wonderful, but there is so much that we don't know about gestational diabetes occurring in CF. We know from the general population that high blood sugars can cause complications in both the pregnant person and the fetus. And there is an urgent need for us to learn what is happening with blood sugar levels during pregnancy in CF. So tomorrow, Dr. Raksha Jain will be talking about the Mayflower study in her plenary. And this is an observational study looking at multiple different health outcomes during pregnancy in people with CF. I want to take this opportunity to highlight the CGM sub-study of Mayflowers. And so in addition to collecting very comprehensive information about diabetes and treatments and complications, participants also have the opportunity to wear a CGM sensor at 4 time points during pregnancy and 1 after. And these time points are in parallel with a very large NIH-funded study in the non-CF pregnant population. And these studies will be so important for informing best practices for the screening and management of gestational diabetes in people with CF. And finally, with our aging CF population, the need for endocrinologists with expertise in CF is only going to grow. The Envision CF program was started in 2016 by Dr. Tony Moran, and this program has provided training and mentoring in CF-specific clinical care and research to over 50 pediatric and adult endocrinologists across the country, myself included. And I am so grateful to Dr. Moran and to all the mentors in this program for the huge impact they've had on my career. And we can all look forward with this program to the growing and expanding CF endocrine community so that hopefully one day all CF care centers will have access to an endocrinologist with expertise in CF. And so, as we look to the future, it is becoming increasingly clear and within reach what are goals to address these burdens and challenges of CFRD for our patients. And this includes personalized approaches to CFRD screening and diagnosis to make screening more convenient and more accessible. We heard earlier in Rebecca's talk all of this exciting research in the CF islets, and hopefully this will bring interventions to delay and maybe one day even prevent the development of CFRD. Trials are ongoing looking at non-insulin interventions for managing CFRD so that hopefully we will have more options and give our patients more choices in how they manage their CFRD. Better tools and technologies to not only improve blood sugar levels, but to reduce the treatment burden that people with CFRD face. A better understanding of glycemic targets, both for lung function and nutritional status, for optimizing pregnancy care, and for preventing diabetes complications in all people with CFRD. And finally, increased access to endocrinologists with expertise in CF. And I am confident that with everyone in this room and all the amazing progress in clinical care and in research, that we will be able to shift this tipping point and bring a better balance to the challenges and burdens that CFRD can bring to help people with CFRD live their best lives possible. And I think Alex said it best. We are so looking forward to what is in store for the future for CFRD. Thank you so much.